All right, we'll talk about LVOT VTI today. All right, we're going to talk about cardiac output, what VTI is, how to obtain it, and then like why it's needed, and then talk about limitations, and we'll do a quick case on it. So, what is cardiac output? Cardiac output is the volume of blood that's ejected from the heart for each minute. So we're going to break it down even simpler. Cardiac output is the stroke volume, so like the amount of blood ejected from the heart during each beat times how fast the heart is beating per minute. We're going to continue to break it down further, and we're going to do cardiac output is a cylinder of blood times heart rate. And then what do we mean by like a cylinder of blood? So each heartbeat, don't think about it as like, when I think about like liquids, you always think about like a volume of liquid being like an amorphous blob of like fluid. Don't think about it as that. Think about blood as like a cylinder of blood. So each heartbeat, the stroke volume is pushing, the heart is pushing out like a cylinder of blood from the heart. So what it's doing is you have this left ventricular outflow tract, and you have that cylinder of blood, and each heartbeat is being pushed out of the heart. The next heartbeat, a second cylinder of blood pops up and gets pushed out of the heart. So that's basically like what I view as like the simplified version of like stroke volume. So again, cardiac output is that stroke volume, which in turn is just that like cylinder of blood times the heart rate. All right, so if we break down that cylinder of blood even further, how do we get the actual volume of that cylinder? That's where you get into VTI and LVOT diameter. Before we go any further, let's just back it up. So you have this cylinder of blood, this like can of soup shaped thing of blood. It's literally just a cylinder. That's it. So for a cylinder, if you're getting the area, you're just doing, you're gonna have to get the height and then the radius, which then you calculate the actual volume of it. Its volume is pi r squared times height. So if we take our like VTI information and we like swap out the original formula for a cylinder, we put in the VTI info. What it means is the VTI is that height of the cylinder, and the diameter or the radius is the LVOT diameter. All right, so where do we get the LVOT diameter? So that's in our parasternal long axis, where you're measuring the LVOT diameter right there. There we go, right there. So that's how you get that portion of the equation. And then VTI is where you do this, where you're kind of getting these envelopes and you're treasuring the area, measuring the area under the curve. All right, so that's VTI. So what does VTI actually stand for? It's velocity time integral. The VTI is an area under the curve. So basically you're measuring a spot, you're measuring the speed of blood over time at one spot. So when you put that gate, which we'll talk about when we talk about like how to actually obtain it, you put that gate at that one spot. So you're putting a gate at the LVOT tract. You're just measuring the speed of blood over time at one spot. And what you're getting is you get like this graph, which is like this wave graph right here. You get this like big wave of the velocity of blood over time. And basically, if you took that graph and you just measured that area under the curve, it gives you one distance. So instead of taking velocity and the time, if you just simplified it and you took the area, you're just getting a distance. So just a straight distance, no other units to worry about. So again, velocity time integral, it's really just the area under the curve of blood, the velocity of blood over time. All right, so how's it done? So step one, you're getting the LVOT tract diameter. So you're gonna get that parasternal long axis, and you're gonna get mid-systole. So parasternal long. You're gonna freeze the image mid-systole. When the valves are open, you're gonna measure this left ventricular outflow tract diameter. So right here. So you're measuring the diameter from inner wall to inner wall right there. And for the most part, it's usually around 2 centimeters. If you're somewhere like up in the ICU and you have a patient, you're going to be doing LVOT or VTI on like multiple times. You're going to be like tracking their like fluid responsiveness. You don't necessarily need to get this every single time. Even if you're in the ED and you want to like see how they respond with a fluid bolus from when they come in to when like they're about to be admitted to the floor, you could just take the LVOT diameter once. So it's going to be a static number. Like their left ventricular outflow tract should not be getting bigger or smaller at all. It should be a stable number. So really, this is like a one-time measure it, and then you don't have to worry about it again. So you have your first data point, and then next you need that second data point. You actually need the VTI. So you're going to obtain that apical 5-chamber view. So you just get that apical 4-chamber and you fan with the probe a little bit more anterior, and you get that apical 5-chamber right here. Then you take your color and you put color right on that apical 5-chamber. And remember, you get the left atrium, and you're going to get flow, you're going to get red flow towards the probe. So flow of blood from the left atrium into the left ventricle is going to be red. And then over the left ventricular outflow tract, you want that blue flow right here because you know the blood is going from the left ventricle out the outflow tract away from the probe. So you want that blue color area. It's like where your marker is going to be. And then you actually obtain your flow tracing. So you have your color on. I would recommend keeping the color on so you know you're in the correct location. And then you're going to get your pulse wave Doppler, and you're going to put that gate right at the left ventricular outflow tract. And this is where you need to adjust that like angle. So depending on the machine, it might be like a touch screen where you just like grab like this area and you angled the flow. So you know like the marker is in the same direction as the directionality of blood. Or like there might be like a actual key on the machine itself, but just know that you need to like adjust the angle so that the marker where like you're measuring the flow of blood is the same direction as how the blood is going. So you put that marker right at the left ventricular outflow tract. And you hit Doppler again, and it's going to give you this waveform. So what you're getting, as we kind of discussed earlier today, you're getting these waves. So you're getting these big envelopes of blood going away from the probe. And remember, this is velocity over time. So velocity being that y-axis and time being the x-axis. So you're getting the velocity over time of the blood flow out the left ventricular outflow tract. That's what these waves, these big envelopes are. And then you can tell we're in the right spot because you're getting these envelopes, you're getting a big wave with a black center in it. That's just telling you you're getting like an accurate pulse wave Doppler measurement or a pulse wave Doppler waveform. And then you can use other things like the snapping of the aortic valves closed, which is right here on top. So this snap right here is also telling you you're in the correct location. So if you get these big waves, one here, another one here, you're starting to get another one here. If you're getting big waves that have empty envelopes, meaning they have black centers, and you're getting like an aortic snap upwards on the opposite side right after the VTI, you know you're in the correct location. So you actually obtained your tracing. Now you have that. What do you actually do with it? So that's when you click VTI or you click like tracing on your on the actual ultrasound. And what you're going to do is do some like fancy finger painting where you're actually going to trace out the wave. So what you're going to do is you're going to trace the entire wave. And what it's measuring is the area right here. And that area is coming out as this distance. So that's that VTI right over there. All right, so normal ranges for VTI. For someone who's got a normal heart rate, say like 20 plus or minus 3. So it's like around like between 17 to 23. And then for people who are like bradycardic or tachycardic, it can affect the VTI. All right, so that's actual VTI. And then if we're doing a full stroke volume or cardiac output assessment, you want to measure the heart rate. So then same thing for either the machine or if you're doing this manually, you want to measure the heart rate. So if you click the machine, you just do peak to peak for these waves because this is one heartbeat and this is another heartbeat. So if you just do peak to peak, the machine will actually calculate the the heart rate and plug it into your overall calculation to give you your cardiac output. So that's it. So you get your LVOT tract diameter. You find your apical 5 chamber. You put your pulse wave Doppler at that left ventricular outflow tract. You get your tracing. You find the area under the curve by actually like measuring it out, and then you calculate your heart rate. And with all those data points, it actually gives you your cardiac output. So like right here, the machine on this one, if you put all those measurements in, it's giving you a cardiac output of 4.3 liters per minute. And then for stroke volume for each heartbeat, it's 69.7 milliliters per heartbeat. All right. So why is this actually needed? So you could follow these various algorithms as far as like what to do with a VTI, like if it's too high or too low. But basically, it's like if you want to look at issues where there can be like a discordance between EF and stroke volume. So like things like heart failure, where like you look at the patient's heart and you're saying like the EF might not be bad, but their stroke volume might be low. Patients who are like hypovolemic, if they're septic, there's a lot of indications for like where you look at the heart and you say like overall that the heart might be ejecting blood like percentage wise okay, but it's actually not enough volume. So like static measurements or like a single data point measurement. You can also use this more of like dynamic, as I said before, like if you're up in the ICU or if you want to like trend patients, clinical status, you can use this to like over time measure it. So like do it when they come up to the ICU and then so forth. And then also just like better hemodynamic understanding. All right, so like looking at these patients, you'd say that the heart overall looks like they have a good EF, like the heart's squeezing pretty well. But if you VTI in these patients, if they're hypovolemic, they might not actually have like a good stroke volume. So even though like it looks like percentage wise, like the amount of blood that's being pumped out of the heart, each heartbeat like looks normal, like it looks like they have good squeeze. That if you actually like measured the volume of blood per each heartbeat, that it's pretty low. So for fluid responsiveness, so if you have a VTI increase of over 15% after administration of like 50 cc's of fluid, that could predict like a fluid responsiveness. So either like if you're doing this and you do VTI and you can do like a 50 cc push, or do something like a straight leg raise and you just like lift up their legs and then repeat VTI, it could give you an indication about like possibly this patient being fluid responsive. So if you go in, they're septic or whatever, they're having like cardiogenic shock, and you do VTI, you wait a second, you lift up their legs, you give them a little fluid blows, and you do it again. It can give you like a rough estimate as far as like fluid responsiveness or not. All right, so far we've talked about like the long version of this, meaning like finding the VTI, finding the left ventricular outflow tract diameter, and the heart rate. So as I said before, the left ventricular outflow tract diameter should be like a static measurement. It's a one-time thing. It shouldn't like their LVOT diameter should not be getting bigger or smaller, rather stay. So you can like kind of forget it for a bit. And then what that gives you is just like your VTI times your heart rate, which is your minute distance. So if you don't want to like track this every single time, or you measured the VTI or like a true cardiac output once, and then you just like want to just do VTI, you can do VTI times heart rate and give you a minute distance. Kind of like the same idea, just it eliminates one of those data points. All right, so just know some limitations of this. One, you have your acquisition errors. So like if the pulse wave gate isn't in the correct spot, you can have falsely high or falsely low, usually falsely low. So like if you take this pulse wave gate right here, so if you take the gate and you have it like right here, like way past like the aortic valves where you're getting the snap of the closure on top. So you're getting the aortic valves closing over there and opening. You're too far in to the left ventricular outflow tract. And then like right here, where they're too much into the ventricle, they're getting these waves that like aren't that same like peaked waves. They're kind of like well-rounded and they really don't have a large envelope. So like this is going to give you like a falsely low VTI. Versus like if you're in the correct location, it's going to be more peaked like that. So you just want to make sure you're in that correct location, like right where the aortic valves are like opening and closing, but you're not getting that opening snap on your tracing. You can have tracing errors. So if you go to trace it and you do too big of an area, you're going to get a falsely high VTI. Or if you do your tracing and you mess up and you go too small, you're not tracing the whole thing, then you're going to get a falsely low VTI. All right, so again, if we think of that amount of blood being shot out of the heart as like a cylinder of blood, with that, we're assuming that that like diameter of the left ventricular outflow tract is like the widest part, and that's like the diameter of like where we're watching blood go out. If there's an obstruction, it's not going to be a true cylinder shape. It's not, it's going to be kind of like deformed and not consistent through that entire like heartbeat. So if you have an obstruction, that can give you a false VTI. All right, other things, if you have aortic regurg, so remember we're watching blood go like through this LVOT tract out this way. So if you have blood with a regurg, like shooting the opposite direction, it's going to mess up your reading. Abnormal heartbeats. So if someone with like an arrhythmia, you can do VTI, just don't do it as like a one-time measurement. So like get a VTI and then do multiple heartbeats. So like measure like 5 and get like the average of the 5. So it's doable with someone who's like AFib or whatever arrhythmia. But just note that you need to do like 5 waves and like average it out. All right. So just like some practice to like show like how this is actually applicable. So say you have a hypovolemic patient, you calculate their VTI. Their VTI here is like 13, so it's pretty low. So you give them a bit of a fluid bolus, like a 200 cc fluid bolus. You recalculate their VTI and you see it's jumped up like way more than that, like 15%. This tells you like this patient's fluid down, like they're going to be fluid responsive. Like when I give them fluid, the heart is ejecting more blood per heartbeat. Like they are fluid responsive. Or like another case, like a patient who's cardiogenic shock. So you see, you do VTI and you see it's really low. You see it's 12. So again, it's pretty low. You do butamine, so like the heart's squeezing much better, and you see the actual VTI like jumps up. So for this patient, it's like doing something that's going to like cause like a better heart squeeze. When we're like it's getting like better contraction, it's going to better increase the VTI. Say like an 80-year-old female, she was brought into the ED for like altered mental status. She's hypotensive, she's tachy, she's frequent UTIs, but she also has heart failure with reduced EF. All right, so like this is where he comes in, like, am I giving fluids or am I giving pressors? So you see this doesn't really tell you one way or another, like your answer. The squeeze isn't that great, but it doesn't really give you an answer about like fluids or not. So you go like the good old IVC, you look at it. It's hard to tell. You can't really see when she's breathing or not. It looks like there's some variability, but it doesn't look like overtly extremely plump. So again, it doesn't really help that much. So say you do VTI for this patient. You do VTI and you get a VTI of like 32.5. So I could tell you that this patient might be extremely like septic. And at this point, like you might need to give like a lot of fluids, as opposed to like giving pressors for this patient. It's like a high VTI indicating like that their heart's like moving significant amount of blood, like more of a septic picture as opposed to like a like cardiogenic shock picture for this patient. All right, and then just to end on a kind of interesting note, so we've been doing VTI, like left ventricular outflow tract VTI specifically. So you can do VTI for pretty much any like valve of the heart or any outflow tract of the heart. Because there's like a principle of like mass conservation, like the blood that's being pushed out of the heart is gonna be the same volume as like the blood going into the heart at any point. Because if there was like a misbalance, there'd obviously be like fluid collecting somewhere within like between that tract somewhere. So if you know the diameters of like either of these areas, so like the subaortic aortic valve, like the mitral valve, the tricuspid, subpulmonic valve. If you know these areas, you can do the same thing with these outflow tracts and then these areas and these VTIs. You can do VTI of any of these and get the same information to get the same cardiac output. And that's pretty much it. So we talked about like what cardiac output actually is, how to get that VTI, like why it's needed and those limitations, and then did a little review. And then just some nice little flow charts as far as when to use VTI or not. That's it.